Thank you for joining us for the 4th Annual Global Summit on Kidney Innovations, Global Kidney Patient Voice, the key to accelerating innovation and collaborative partnership event presented by the American Associated Kidney Patients and the George Washington University School of Medicine and Health Sciences. My name is David Rodriguez, and I am a AAKP Board of Director, a member of the AAKP Executive Committee, and an AAKP Ambassador for the state of Texas. I am also a kidney patient. I have experienced hemodialysis and have been blessed to have a kidney transplant for the last 11 years. And more recently, I received a liver transplant in January 2022. Throughout my professional career, I was a former patient relationship specialist at University Transplant Institute in San Antonio, Texas. I currently serve as an appointed member of the Scientific Registry of Transplant Recipients, Patient and Family Advisory Committee, and have participated in several industry-related projects to review clinical trial design and patient education content. I have also authored a patient voice editorial in the Clinical Journal of American Society of Nephrology titled Kidney Disease, Burden, and Kidney Transplantation, a True Story. My journey with kidney disease began in 2008 when I was diagnosed with focal segmental glomerulosclerosis, more commonly known as FSGS. It was a difficult time in my life, as I already watched my father battle kidney disease. However, knowing that others in the Hispanic culture, like me, are also at high risk for kidney disease, I choose to dedicate my advocacy work over the last 14 years to helping fellow patients as well as those within my local community. Being part of AAKP allows me to be the voice for my community and the state of Texas, and help represent fellow kidney patients across the country and across the globe by sharing my personal transplant experience and promote chronic kidney disease awareness. Throughout AAKP Global, launched in 2019, AAKP is engaged internationally because we are committed to educating patients and leaders across the globe on the importance of kidney disease prevention, new innovations in treatment, and the opportunity to save more lives. We believe that united patients' voice can drive innovation and the policy decisions that determine timely regulation and payment for new and safe care treatments. Globally, we are working with patients, medical professionals, researchers, and medical industry allies to cultivate a united consortium led by patients. AAKP believes this international consortium can advance innovation and change kidney care in countries where healthcare systems and/or infrastructure do not support patient consumer choice and/or access to care treatments. For this session, I am pleased to introduce not only a friend and an ally of AAKP's, but one of George Washington University's finest, Dr. Ehsan Nobakht. Dr. Nobakht is an assistant professor of medicine of George Washington University School of Medicine and Health Sciences, medical director of Falls Church of Somatus Dialysis, and medical director of Fresenius Kidney Care Dialysis in Hyattsville, Maryland. Dr. Nobakht joins us today for our session on long-term management of COVID and variants. Dr. Nobakht, I turn it over to you.
Hello. Thanks to the organizers of Kidney Global Summit. I'm going to talk about the long-term complications of COVID-19 with implications for general population and patients with kidney disease. The COVID-19 pandemic continues to be a public health crisis. There have been more than 500 million cases of COVID-19, with more than 6 million deaths globally. In the United States, there have been more than 90 million cases of COVID-19 with more than 1 million deaths. And since COVID-19 infection can be mildly or even asymptomatic, the actual number of the patients who have been infected with COVID-19 infection is higher than these confirmed cases. And this has a very important implication because now we know COVID-19 have long-term complications. The acute phase of COVID-19 infection may last 3 to 4 weeks, but some patients will have persistent symptoms such as fatigue, weakness, shortness of breath, anxiety, depression, cognitive disturbances, the so-called brain fog, and development of other conditions such as chronic kidney disease. So what is the definition of post-acute COVID-19 syndrome or long COVID? COVID-19 is a multi-organ disease. In the acute phase, in addition to the lung, it can involve other organs, including the kidney. Also, in the chronic phase, COVID-19 can cause persistent symptoms such as fatigue, dyspnea, chest pain, cognitive disturbances, weakness, and decline in the quality of life. So what is the definition? The post-acute COVID-19 syndrome is defined as a syndrome characterized by persistent symptoms or delayed or long-term complications beyond 4 weeks from the onset of symptoms. And where does that 4 weeks cutoff come from? This is based on the data showing that replication competent SARS-CoV-2 is no longer isolated after 3 to 4 weeks. In other words, the acute phase of infection is resolved by 3 to 4 weeks. So what is the underlying mechanism of post-acute COVID-19 syndrome? Not everyone would get persistent symptoms. So what is the cause of that? So the exact mechanism is not clear, but some recent research provided mechanistic insights. Continuing activation of inflammatory cells, CD8 T cells, and also elevated levels of protein associated with apoptosis, tissue repair, and epithelial injury was noted in the lung on those individuals with ongoing respiratory symptoms. Another study, a longitudinal multi-omic study of more than 300 patients, showed that pre-existing type 2 diabetes, latent EBV reactivation, circulating SARS-CoV-2 RNA fragments, and also some specific autoantibodies were found to be associated with long COVID. Also, bystander activation of CMV-specific T cells was found to be associated with the GI symptoms of long COVID. Post-acute viral syndrome is not unique to COVID-19. Survivors of previous coronavirus infection, such as SARS epidemic in 2003 and the Middle East respiratory syndrome outbreak in 2012, also showed a similar constellation of persistent symptoms, which this reinforces the clinical significance of long COVID. So how common is long COVID? Not everyone after COVID-19 infection will get persistent symptoms. A 60-day outcome among more than 1,200 survivors of COVID-19 hospitalization was studied by telephone survey. 480 individuals completed the survey. Among them, 33% of the patients reported persistent symptoms, including 19% with new or worsened symptoms. In addition to the physical and emotional symptoms, inability to return to normal activities, inability to return to work with associated financial loss were common among hospitalized COVID-19 patients. However, we have to be mindful with interpreting the result of such studies because the loss to follow-up may not be random. Long COVID is not limited to only to those individuals with more severe disease requiring hospitalizations. Even individuals who did not require hospitalization reported long COVID. At 12 weeks, up to 38% experience at least one symptom: female sex, increasing age, obesity, smoking, vaping, hospitalization with COVID-19, deprivation, and being a healthcare worker were associated with the higher probability of persistent symptoms. The data from UK showed high prevalence of long COVID, and even some patients reported symptoms for 2 years. The studies, the community-based studies from other places showed lower prevalence of long COVID. A meta-analysis of more than 40 studies from different countries in the world showed a long list of the symptoms, reported symptoms. But the main question is, what symptoms can be attributed to COVID-19? Not every symptom in an individual with prior infection of COVID-19 is attributed to COVID-19. In a very recent study, well-conducted study of more than 70,000 participants with the match control group, also correcting for the individual symptoms before COVID-19 infection. In this study, 13% of participants, approximately 1 in 8, reported symptoms attributable to COVID-19. Interestingly, some of the symptoms such as stomach pain, diarrhea, or even cough return to baseline within 50 days of diagnosis of COVID-19. So who is more likely to develop long COVID? People who had more severe disease requiring hospitalization, especially those who required ICU admission, are more likely to develop long COVID. Also, those individuals with underlying health conditions prior COVID-19, as I mentioned, type 2 diabetes, smoking, obesity, these individuals are more likely to develop long COVID. Also, unvaccinated people are more likely to develop long COVID, as well as multi-system inflammatory syndrome. Those individuals with MIS during or after COVID-19 illness are more likely to develop long COVID. How about our patients with kidney disease? So the relationship between COVID-19 and kidney disease is bidirectional. Having chronic kidney disease can increase the risk of COVID-19 complications. On the other hand, having kidney disease in the setting of COVID-19 infection can lead to persistent kidney dysfunction. You can see on the right panel, you can see a conceptual model of trajectories of kidney function after COVID-19 infection. As you may see, some individuals after COVID-19 infection can have a full recovery of kidney function. Some may have a slowly progressive decline, and some individuals may end up having a rapidly progressive decline in the kidney function, resulting in development of end-stage kidney disease. So that was a conceptual model which was published in the past, and now, based on the data, is somehow evidence-based. So now we know that the COVID-19 survivors are more likely to have new or worsening of kidney disease. And this was based on a study done by in the US VA health system, showing that in those individuals with COVID-19 infection compared to those who did not have COVID-19 infection, the renal outcome, the adverse renal outcomes were more likely, including acute kidney injury, decline in GFR, development of end-stage kidney disease, and having make major adverse kidney events, a composite outcome of all-cause mortality, development of end-stage kidney disease, and more than 50% decline in GFR. The excess decline in GFR was more in those individuals who required hospitalization, and it was more pronounced in those who required ICU admission. I'd like to highlight a very important point. As you see here, the excess decline in GFR was also noted in those people who had less severe disease, in those individuals who did not require hospitalization. And this has a very important implication because this includes a very large number of population. So the nephrology community, the scientists should further investigate the mechanism of kidney disease in COVID-19 survivors. And we should be prepared, we should develop strategies to meet the growing demand of kidney care for COVID-19 survivors in the future. So what can we do at this point for our patients? As a consequence of public health policies, development of vaccines, having immunomodulators, having using antiviral therapies, the mortality of COVID-19 has decreased. Also, now we have new vaccines. The FDA authorized Novavax, a new vaccine, which is not an mRNA vaccine, which is somehow a more traditional vaccine, and it brings another option for the patients. But the main concern is the emergence of the new variants. With the emergence of Omicron variant, that resulted in increased number of cases and also increased number of deaths, which was more likely in unvaccinated people. However, The breakthrough infection, the infection in vaccinated people is also increasing. I'd like to highlight the importance of the booster shot. So the vaccines are not perfect, but they're effective against severe disease. And with regards to Omicron variant, 2 doses of the vaccine provided limited protection, but having the booster shot significantly increased the protection against Omicron variants. How about our patients with kidney failure? There was an initial concern that the patients with kidney failure they may not have good response to vaccine because their immune system is not as robust as general population. The early data showed that the antibody response to vaccine was good among our dialysis patients, and now we have outcome study showing that there is a lower risk of severe COVID-19 infection in dialysis patients compared to those who were not vaccinated. So COVID-19 pandemic is not over. The cases are increasing and it remains a deadly condition with long-term complications. So what can we do for long COVID? How can we prevent long COVID? The best way to prevent post-COVID condition is not to get infected, is to protect yourself from infection. And the best tool we have is our vaccines. As I said, vaccines are not perfect, but they're effective against severe disease. And also with regard to long COVID, people who are vaccinated, even if they get breakthrough infection, they are less likely to develop post-COVID conditions compared to unvaccinated people. Unfortunately, the virus is becoming better and better to escape our immune response. The Omicron subvariants BA4 and BA5 can substantially escape the neutralizing antibodies induced by both vaccination and infection. That means vaccinated people can get infected, even those people who had the infection with prior infection can get reinfected. And this brings us to the important topic of need for updated vaccines. The virus which is circulating now is different from the original virus. So our vaccines should be updated as well. And the vaccines developers are working on that, and hopefully in the future we have somehow a variant-proof vaccine. With regards to the therapies for long COVID, at this point there is no approved therapy for long COVID. There are many randomized trials underway to see the effect of different intervention on long COVID, but at this point we do not have an approved therapy. With regards to the effect of the already authorized antiviral on long COVID, at this point we do not know. There is no registered studies for molnupiravir, Paxlovid, remdesivir, which are authorized for treatment of long COVID. And it's very important to know the effect of these medications on long COVID. At least the participants of the original trial can be followed and assess the outcome to see what is the effect on the long-term COVID. With regards to Paxlovid, the patient with kidney disease with GFR more than 60, they can use the regular dose. And the individual with the GFR between 30 to 60, they can use the reduced dose of Paxlovid. But unfortunately, the appropriate dose of Paxlovid in patients with more advanced kidney disease is not known. However, some experts are suggesting that a reduced dose of Paxlovid can be used in patients with more advanced kidney disease, but a very detailed discussion about the risk and benefits of this approach is needed. COVID-19 survivors need to have regular follow-up in a multidisciplinary fashion. That follow-up should include cardiopulmonary assessment, neuropsychiatry assessment, primary care, nephrology, hematology. All needs to work together to ensure the COVID-19 survivors to receive the appropriate care. In conclusion, long COVID is a clinically significant condition which may impact millions of people. Forecasting of burden of long COVID is needed. Implications of long COVID on healthcare system can be enormous. Multidisciplinary collaboration is essential to provide integrated care to COVID-19 survivors, and the nephrology community will need to further investigate the mechanisms of post-acute COVID-19 kidney disease and develop strategies to meet the growing demand of kidney care for COVID-19 survivors. Thank you for inviting me and watching this presentation.
Thank you, Dr. Nobakht, for a great presentation on an important topic that continues to evolve and impact the kidney community. We appreciate you taking the time to share your insights and expertise.